A very good afternoon. We start with the class on varicose veins or varicoceles. Now, this topic in urology is a small topic, a very high-yielding topic, probably given the reason that there are multiple short notes which are asked in this one. There are multiple MCQs which are subcategorically asked around this one, but we shall try about this one in a systematic manner. Now, when you start about a varicocele, what is a varicocele and how do you define a varicocele? Remember that a varicocele is defined as a varicosity of the testicular veins, definitely in the spermatic cord, and with the reversal of flow in the testicular vein. Now, talking about the word varicose means, as you know from your class on varicose veins, dilated veins, tortuous veins, elongated veins are the three things. So let us talk about dilated veins, tortuous veins, elongated veins are the three ends of the system that you should know about what is a varicose vein. Now, what is most important is, what is important in all varicose veins is reversal of the flow. Now, if you are talking about the reversal of the flow, remember that we are talking about testicular veins, and when you talk about testicular veins, that means testicular veins will drain the blood in the spermatic cord, and the blood reaches into on the right side to the inferior vena cava directly, and on the left side, remember, it drains into the left renal vein. So I have drawn a very schematic picture. On the right side, remember that it has drained into inferior vena cava. On the left side, it has drained into the left renal vein. So that is all about the story about the testicular veins. Now, but there is one hitch in the story. When you talk about the testicular veins, and we'll talk about varicoceles in a minute, when it starts with this venous system, initially there are around 15 to 20 such veins which are seen at the level of the spermatic cord in the scrotum. Now, the more you talk about them at the level of superficial ring, I will draw a very schematic picture. These veins will now coalesce to only become 1, 2, 3, and 4. The minute you talk about the deep ring, the things changed a bit, and then these ones will coalesce to become 1 and 2, and these two immediately when they enter into the retroperitoneum will become one testicular vein. As I have said, the one testicular vein, I will again recap. If I draw the renal vein, then this testicular vein will drain the right side into the vena cava, the left side into the left renal vein. Now, so this is all about the gross anatomy. There is a whole system of valves in the system which will allow the blood to go up but will not allow the blood to fall down. Please remember that. So this is all about the system. It looks like somewhat like the inferior extremity, not exactly. So what is a varicocele again? So literally enough, a varicocele will always mean that the blood has to come backwards along the testicular vein. Now, why does a varicocele happen like that, or why should a varicocele happen, and what is etiology? Now, as I've said, these are small topics, short notes, so we need to know much less things about this. Etiology are two. One is a primary varicocele, and another one called as a secondary varicocele. Now, when you talk about a primary varicocele, it means 95% of the time this is idiopathic and does not have any particular bearing into what the reason for this one, but is usually seen in tall men, no particular reasons, and they are thin. Now, when you talk about a secondary varicocele, it is usually due to a renal cell cancer, and particularly on the right side. Now, what is the story about this? Now, if you understand the story about a secondary varicocele, it technically means that this is the right kidney. In your kidney cancer class, as you know, that we have discussed about what the interesting thing is about this one, and then we have discussed about if this is the tumor grows into the renal veins like this, and what technically happens is this tumor invades into the vena cava. Now let us talk about your varicose or your testicular veins, the right one and the left one. So what happens is our secondary varicoceles are more commonly seen on the right than the left. But remember that when should you suspect in a secondary varicocele a renal cell cancer? Now, when I say about a renal cell cancer, that does not only mean a kidney cancer. Sometimes it has been also observed that retroperitoneal tumors, which can compress upon the drainage side of the renal vein, and this one can also produce this one. So this is all about a renal cell cancer story. About this, now when will you suspect a renal cell cancer? One, when the tumor or the varicocele, sorry, is on the right side. Number two, when it is seen to rapidly evolve another arm. Number three, when it does not reduce very quickly. And finally, is when it is seen in an elderly. As I've said, this is seen usually in young people, okay, and remember that these are seen in elderly, okay. They don't look here now. So this is all. So this is all about things that you should note about in a primary varicocele versus a secondary varicocele. Now, talking about the clinical features and a bit of pathology associated with it. Now, when you talk about the clinical features of varicocele, what is important for you to remember is that varicoceles, if you see the video and the picture associated with this video, now this is how a varicocele, now this is how a varicocele is expected to look like. Now, so when you go to the screen now, when you talk about the clinical features of a varicocele, what becomes important is varicoceles, particularly the primary ones, are seen in young adults. Number two, they are seen in tall people. No particular reasons why. Maybe the testicular vein is longer. Left, definitely thrice as more common on the right. We will see the reasons why. What is important is when you talk about the clinical features, it presents with usually a scrotal swelling rather than an inguinal scrotal swelling. And as I've shown you in the picture about the scrotal swelling, let me see if I have the picture with me. Yeah, I think I have the picture. Now, when you talk about the scrotal swellings, now as I've said, varicoceles will usually present as a scrotal swelling rather than an inguinoscrotal swelling, and all the veins that are down there, usually a prominent bunch of veins. Now, these veins will typically show are more prominent on standing and doing a valsalva. Next one, these veins are more prominent on standing and valsalva, as I've said, are reducible when the patient lies down. If it is not reducible, think about a renal cell tumor. Next one, these veins will show a positive coughing pulse. It's not very well appreciated though, and until unless the varicocele becomes pretty big, and rarely you may find the testes of the same side to be less in volume than that of the contralateral side. This is more of a radiological finding than of a clinical finding. So please remember these ones. Reducible on lying down, positive coughing pulse, but at the beginning and at the end, remember the difference with the hernia is that this is a scrotal swelling rather than an hernia, which is an inguinoscrotal swelling. So please remember, standing valsalva, it is a reducible swelling and has an positive cuff impulse. Remember that this is a testis with this story. So we have talked about all the points that you are required to know in a varicocele clinically. Now let us come to the question around why should you have a varicocele more common on the left side rather than having this on the right side. Now, People for an examination purpose will say that, as I've said in this picture, there are usually a group of reasons. I will discuss them. Reason number one that people propose is the left testicular vein is longer than the right testicular vein. Okay, so this is the first reason maybe. The reason number two is that the left testicular vein will drain at a right angle to the right testicular vein, and this, when you talk about the angulation with the inferior vena cava and the straight one, the vector in this one gets a more resistance rather than this one, which acts as an obliquity, and this obliqueness blocks the mouth of this one. Reason number three that we propose is includes about the draining of the adrenal vein over this one. We will take up this slide. Give me a sec. Right now, so there is a draining of the adrenal vein from the left adrenal vein to the mouth of the left renal vein, the left testicular vein, and the vasospasm is responsible for the closing of the mouth. Next one, what people propose is the superior mesenteric artery blocks the left renal vein. So the fourth one will be the superior mesenteric artery has a nutcracker effect on the left renal vein, and thus the testicular vein drainage, as you see, is more impeded. Not a very strong reason. The left colon is always loaded. Maybe it compresses upon the left testicular vein. The sixth one people propose is, now, as I've said, the sixth one what people propose is that the valve system is much weak on the left side than that of the right, and maybe one among the reasons on that, no particular reasons that are known for this. And finally, people say that probably the left testicular vein, as I've said, the left testis hangs down lower than the right testis. It hangs down lower than the right testis. And hence, basically, the column of the blood on the left side is much gainful than the right one, which is a smaller column of blood. Hence, the left testicular vein undergoes a tortuosity to make a varicocele. Now, after this is done, so let us talk about after this is done, then we talk about the next one, how do we investigate a patient with a varicocele? Now, investigations in a varicocele are very straightforward. Investigations, remember, in a varicocele are always very straightforward, and we can remember them by doing. The first one is, remember about a color Doppler, and color Doppler will tell you about the most important entity of all, because in the clinical features, what has to be said and added is, remember, varicoceles are usually a part of infertility. Now, they are responsible and are said to be a cause of male infertility and are said to be one among the commonest causes of reversible male infertility. So, your investigation of choice is always a color Doppler in which you have two important findings. Finding number one is the reversal of the blood flow. That means blood is going in the opposite way in this one. Point number two is the testes of this size, or the contralateral, or the ipsilateral side is usually reduced in volume to 20% of the contralateral side, or a less than 2 ml in volume. May speak about this, but remember what I will go for is always a reversal of flow. Some people propose a diameter more than 3.5 millimeter enlarged testicular veins. But what is important and the only criteria that I will like to mark in an exam is a reversal of flow. Apart from this, if you are planning investigations, so if color Doppler is said to be your confirmatory investigations, please remember, color Doppler is said to be your confirmatory investigations. Now, you can now, before your pre-operative investigations, I need only one. apart from the routine preoperative test that you do, is a semen analysis. And as I have already said, this is responsible for subfertility. Now, even before you operate on a patient of varicocele, it is important for you to document what is the baseline sperm count, what is the motility in the sperm, what is the morphology of the sperm before I go for a surgery for a varicocele. Now, talking about the management of a varicocele. Now, question number one, varicoceles are pretty common ones in the human population. When you talk about the management, now, as I've said, management, before we talk about management, there is only one concern of infertility, and examiners who are having a good day will ask you, how does infertility or technically subfertility happen with a varicocele? Why does it happen with a varicocele? The reason number one to discuss about is very straight. The testis is normally expected to produce a spermatogenesis at 32 degrees centigrade. If it increases up till 37 degrees centigrade, even sometimes up to 40, the spermatogenesis is remarkably decreased by twice. So remember that testis always prefers a cold environment to work. Now it cannot work in a summer season. If the blood flow is increased, this is exactly what is happening to the testis. Problem number two. Now, when you talk about the problem number two, what is important in this one is the increased blood flow will now promote and more enzymatic activity in the Sertoli cells. Now, the Sertoli cells are nourishing cells which use glycogen, and if the glycogen gets eaten away, what happens is the spermatic cells, which are responsible for eating them, they get very unhappy, and the sperm size decreases. What is number C is that the Leydig cells, which are responsible for forming testosterone, their proliferation decreases and thus testosterone production decreases to now again affect the testes to thus decrease in size and volume and function. Number fourth is some people say that there is an increase in intratesticular blood supply, and again that is hampering all of these three processes A, B and C. So we have talked about why does varicocele produce. So what are we going to do for varicocele? Next is, if it is when, then when should you think about a surgery in a varicocele? Again, the answer for this is very straight. You talk about infertility, and remember that as I've said, subfertility, infertility. What is important is that what are the criteria? Number one, when the female partner has been ruled out that she does not have any problem, that means female is always, the thing is okay from her side. The sperm count shows features of hypospermia, not agiospermia. The motility and the shape of the sperm has changed. So remember that it again, as I've said, is a reversible cause of infertility. Remember that around 10 to 20% of people who are having this one will not get their fertility back. Particularly remember if it is delayed beyond 15 years of age. So people have a strong doubt as to what is the correct age. But the more the age that you operate on, the less the sperm count. Some people propose 20 years, some people have proposed even 25 years. The second reason that we operate, apart from this one, is an recruitment in army, police, etc. Some people will come for a cosmetic reason, which is probably the least important of all. But what I will go for always for an exam purpose is about infertility, which is the most important thing. Talk about the last one. The last one in concern is what is the surgical management. Now, surgical managements have evolved over time. If you talk about what is the surgical management, this is the testes, and then this is the bunch of veins that are coming from the testes. And as I have said, if this is the superficial ring, this is the deep ring, this is the retroperitoneum, our approaches have changed drastically from this last. Now, at the level of superficial ring, how many veins are there? 4 veins. These will unite at the level of the deep ring to form how many veins? Two veins. They will unite to form single vein. Now, the operation of choice that is standard of care is a Palamose operation, which has been done at the retroperitoneum, and remember, is usually always done at the retroperitoneum, and some people are proposed after the deep ring. Operations can be a laparoscopic one, which is said to be the standard of care now, in which it is an easy procedure to do. Just find it transperitoneally, remove the peritoneal covering and the deep ring, find the testicular vein. You can also do an open procedure, but it is not a very easy operation, and which you need to put an incision. Remember, just medial to the anterior superior iliac spine, and then make a mark around at the level of the deep ring, dissect around the spermatic cord. This is the deep ring, cut the fibers of the internal oblique, and then you will get hold of the single testicular vein. So this is all about the Palamose technique, which is associated with a bit of complications, which will include, remember, two groups of complications. One is injury to the testicular artery, remember, is injured in 1% of the cases, and that will lead may or may not to a testicular atrophy. What is important, people propose, but what is purely the luck of the patient will be. The testis is known to have a blood supply, not only one. The major one always is the testicular artery, but it can also receive artery to the vas and artery to the cremaster. So please remember this one. Artery to the vas and artery to the cremaster are seen. And if it is artery to the vas and cremaster, even if you ligate this artery, maybe, the word is a big maybe, it will prevent the testicular atrophy. Another problem that is there is a hydrocele formation, which is again seen in 1 to 2% of cases. Probably because of the lymphatics are disrupted. So this is what is the standard of care for the Palamose operation. What is important is that if you do this in the inguinal canal, this is an inguinal approach, which is still some surgeons will do that, and is called as a modified Ivanasevich operation. Ivanasevich approach is called as an inguinal approach, where you ligate these ones. Scrotal approach is a very old approach, is not to be done now, because you can see ligating one vein is much easier rather than ligating 15 veins, which makes it a very bloody one. So we have discussed about what is always the approach about these ones, varicocele. What has come nowadays is a new approach of a minimally invasive radiological procedure, and as you can see in this one, is a minimally invasive radiological procedure in which you enter through one side, usually on the right side. You take the catheter and cannulate the left or the right testicular vein, whatever may be your case, and then the minute you ligate this one, you give a gel foam coil or a Venturco coil and do an angiogram. As you can see, blood should be going up, blood should not be going down, but in a varicocele, due to incompetent valves, the blood is going down. So this is the radiological coil embolization, which is now the standard of care. So with this, we have finished out. The varicocele.